this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP and for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
We have Dr. Amanda Apato from the Rush University Medical Center.
I'll go ahead and get started. So for this month's journal club, we picked the SQuID protocol using subcutaneous insulin for diabetic ketoacidosis. The objectives of this presentation is going to be to talk about the pathophysiology, the presentation, and how we treat these patients with DKA in our emergency department. We're going to talk about this recently published journal article looking at the safety and efficacy of subcutaneous insulin in DKA, and then relate that all back to how we can currently be using subcu insulin in our emergency department for this practice. Starting with some background. So diabetic ketoacidosis, or DKA, is a life-threatening complication of diabetes, but is entirely preventable. It has a pretty widespread incidence, but is more common in children than adults, as we see a lot of our kiddos presenting with that initial DKA for diagnosis of diabetes. Pathophysiology-wise, it develops due to this insulin deficiency, so the pancreas not being able to get any insulin, so they become insulin deficient. And due to that, the body increases their counter-regulatory hormones, so glucagon, catecholamines, cortisol, etc., leading to this increase in ketone body formation, this acidotic state, throwing them into this fatty acid metabolism rather than being able to use glucose due to that insulin deficiency. So for diagnosis-wise, it's going to be on a multitude of things. Really, we're going to be looking at our plasma glucose being greater than 250. These patients will be acidotic with a pH generally less than 7.25, but it can be even lower than 7. These patients will have variances in their serum bicarb. They'll have the presence of ketones, with primarily being beta-hydroxybutyrate, the one that we're interested in. They'll have a positive anion gap, and then they could have variance in their mental status as well, if they're alert all the way to being completely altered and in a coma-like state. For the sake of our subcutaneous insulin, they primarily have been using subcutaneous insulin for DKA management in the mild to moderate group. So these patients still meet the definition of DKA. They'll have high blood sugars, positive ketones. That anion gap will have already been developed, but their pH is generally greater than 7. So they're not incredibly acidotic, with that severe category being a pH less than 7, but they still meet that acidotic state with that pH anywhere from 7 to 7.3. And they should be alert to potentially drowsy in terms of their mental status. So for the pillars of DKA management, really comes down to 3 things. We're going to be starting these patients on fluids, as they're generally in a dehydrated state when they come in. So initial fluid boluses, and then continuing our maintenance fluids. We're going to be checking electrolytes and repleting as needed. Potassium is going to be the big one that we're checking and repleting, because insulin is going to shift that intracellularly, and they're generally going to need some type of replacement. And then we should be getting serum or serial BMPs to be checking our bicarb, our anion gap, and our potassium as well. And then the last pillar is really going to be our insulin, getting it started, whether it be that insulin infusion with the regular insulin given IV, or we can use our subcu insulin. So that's going to be our rapid-acting insulin, either insulin Lispro or Aspart. And the dose generally used there is 0.2 units per kilo every 2 hours given subcu. So kind of looking into some literature as to why IV insulin has been the mainstay of treatment for decades. So this is an outdated trial from 1977 that looked at regular insulin given IV versus subcu versus IM. And as you can see, it's pretty small groups, 15 in each, that were given those various routes of regular insulin. And they saw that they compared fall in glucose and ketones, and saw that the IV insulin group had a greater fall in their blood glucose and their ketone levels within that first 2 hours, but really no significant difference after that initial 2-hour mark. And that's kind of shown on this graph here. As you can see, it was an initial drop quicker in that IV group compared to the subcu, and IM was included in this aspect, but we don't do IM insulin any longer. So the authors concluded from this trial back then that the sub-Q delivery of insulin was effective, but inferior because that IV insulin had that greater drop within that 2 hours for our blood glucose and our ketones. So we can see why IV insulin has been the mainstay of DKA management for several decades. But there's been some emerging literature looking at sub-Q insulin in this patient population. This was a 2016 Cochrane analysis that looked at 5 different randomized controlled trials. In our mild to moderate DKA patients, could they get sub-Q insulin versus their IV regular insulin? So of those 5 trials, 4 of them used Lispro as their rapid-acting insulin, and 1 trial, which was actually done here at Rush, was used aspart as their rapid-acting insulin given sub-Q. And from there, they had 110 patients that received sub-Q insulin and 91 that were on the mainstay regular insulin infusion. And they really saw no difference in time to DKA resolution for either the Lispro or the aspart groups. Similarly, very similar rates of hypoglycemia. That wasn't statistically different either. And the length of median hospital stay was roughly the same for all the different groups as well. So from this Cochrane analysis of those 5 trials, they concluded that there was really no advantage or disadvantage for sub-Q insulin versus IV regular insulin in this mild to moderate DKA patient population. So it could be a good option in that specific group to get these patients off of it, not having to get infusions or being admitted to the ICU. So that led to the development of this trial, which I'm going to talk about, that was recently published here. So the SQuID protocol was a quasi-experimental pre-post study done at a single center urban academic hospital. It was published this last year in February. So this hospital of note did not have an intermediate care unit, and they were not able to use IV insulin infusions outside of the ICU. So they really implemented this protocol to see if they could prevent ICU admissions, manage these mild to moderate DKA patients without having to admit them to the limited availability of beds available in their ICU at this small center. So the objective of this study was to describe the efficacy and safety of this sub-Q insulin protocol for those mild to moderate DKA patients and see if there was a difference. For study timeline, they used 2 historical control groups, and due to the lovely pandemic, there was a pre-intervention group, the pre-SQuID group, which was from November 2020 to May 2021. But then they also did a group before that, the pre-COVID group, from August of 2019 to February of 2022, compared to the post-SQuID group, the post-intervention after they implemented this protocol, which was from August of 2021 to February 2022. So they included any emergency department patient that was over the ages of 18 that met that criteria listed below for mild to moderate DKA, or if patients were just had that discharge diagnosis of DKA and had received insulin, they were also screened for inclusion. Patients were excluded if they met that criteria for severe DKA, so a pH less than 7, if they had a bicarb that was less than 10, I believe. They did also patients that had altered mental status, were pregnant, had any serious infection that was currently ongoing, if there was a concern for an MI, active comorbidities, they listed that as end-stage renal disease, CHF, if they were on any active immunosuppressants as well, that was considered a comorbidity. If they had to go for a surgical procedure, and then if the provider just determined the patient to be too ill to be included in the study, they were also excluded. So this is the SQuID protocol that they implemented. The patients were getting blood glucose checks every 2 hours. And then based on those blood sugars, they were followed on this pathway. They were also started on 0.45 of NS at 150 mLs per hour after their initial 2 boluses, getting serial BMPs every 4 hours and repleting their potassium as needed. So they would start with that blood sugar greater than 250, get the 0.2 units per kilo given sub-Q, continue the fluids at that maintenance rate. And then once their blood sugar fell below that 250 is when they would add dextrose to the fluids so that they could maintain their blood sugar and keep the insulin going. And they would drop the insulin sub-Q to 0.1 units per kilo as well. And so forth and so on based on their subsequent blood sugar checks every 2 hours. They would be adjusting the protocol based on what's listed here. So for endpoints, they looked at 3 different buckets of endpoints: the fidelity endpoint, so the adherence and the implementation and the effectiveness of the SQuID protocol itself. They used the amount of point of care glucose checks per hour as their marker for fidelity, but that's the only thing that they assessed in terms of that fidelity endpoint. For safety endpoints, they looked at the frequency of hypoglycemia events, basically meaning those patients required any type of rescue dextrose because their sugars fell too much. And then lastly, their main thing that they were looking at was operational outcomes. Was the ED length of stay different in terms of sub-Q versus IV insulin? And did they have a difference in ICU admission rates? For statistical analysis wise, they calculated using a one-sided Mann-Whitney U test to determine a difference of less than or negative 2.9 hours in that intervention group to be statistically significant for that ED difference in length of stay. They use otherwise descriptive statistics, chi-square or Fisher's exact for those differences between ICU admissions. And then they did a one-way ANOVA test for those three different groups, the pre-SQuID, pre-COVID, and post-SQuID groups, to determine if there was a difference in mean monthly ED length of stay between those groups. Getting into the results. So for the intervention group there on the left, there was 218 patients that were screened for inclusion. 41 of them were excluded mainly for being to be categorized as severe DKA. So of the 177 patients that were included, 78 were on the SQuID protocol and 99 were on the traditional IV insulin protocol. And then for our historical controls, pre-SQuID and pre-COVID, there was 54 of those excluded, all for being severe DKA patients. And then of the 324 that were included, 163 of them were in the pre-SQuID group and 161 were in the pre-COVID group. For baseline characteristics listed there, post-intervention, as well as our historical cohorts. As you can see, the age was generally younger for the SQuID group with that median of 41.5 years, where our traditional pre-SQuID and pre-COVID groups were on the higher end of the 40s to the mid-50s in terms of age. Also, in terms of sex, there was more females in the SQuID intervention group compared to the others. They also had a lower acuity, so an emergency severity index being a higher number, so 2 or 3, but lower acuity overall compared to the traditional pre-SQuID and pre-COVID groups. And the SQuID group had more percentage of discharges compared to the traditional pre-SQuID and pre-COVID groups as well. So getting to our endpoints, so for the fidelity endpoint, they looked at glucose tests per hour and saw that on average, they were getting each group, the SQuID, traditional, pre-SQuID, and pre-COVID, were all getting a median of 1 glucose test per hour when the protocol was to be every 2 hours, but they were still getting them every hour. No differences were seen there in terms of that endpoint. For the safety endpoint, they looked at the rescue dextrose and saw that there were 2 patients in the SQuID protocol that did require rescue dextrose being administered, and then 1 patient in the traditional IV insulin group that required rescue dextrose as well, but that was not statistically different as either. The main thing that they found from this study was a difference in ED length of stay at -3 hours. So patients that got the SQuID protocol were likely to get out of the ER 3 hours quicker than the patients that got traditional IV insulin infusions compared between the different groups. And that's kind of shown there on that plot to the right. You can see that just the length of stay in terms of the ED for hours was less for the patients that got sub-Q insulin compared to the other groups. Similarly, for operational impact, they looked at ICU admissions and saw roughly across the board 43 to 49% of patients still went to the ICU in all the different cohorts, the post-SQuID, pre-SQuID, and pre-COVID. So no statistical difference was seen in terms of ICU admission for this patient population. And then they did a regression analysis and saw no significant difference in terms of monthly ED length of stay for all patients that visited the ER in terms of that, as well as for the number of ED visits total. So just no differences across the board in the monthly numbers. So that brings us to our discussion. Really, they showed that sub-Q fast-acting insulin protocol could be a really great option for our mild to moderate severity DKA patients. They led to a reduction in ED length of stay, which could help with our ever-ending issues of waiting room times and border burden. Getting these patients out of our ED and upstairs could help us get to see other patients and prevent those exuberantly long wait times that patients have been experiencing. And there's that also potential greater impact on reducing ICU admissions with more widespread use, specifically for facilities that don't have ICUs or intermediate care beds available. And we can prevent those patients from having to wait in our ER for those beds to open up. But there are a lot of confounders from this study to consider and a lot of things that could be further investigated in future studies. So I just want to talk about some strengths of the study. It is very relevant. It adds to the limited amount of data that we do have available for sub-Q insulin and DKA. We have some good emerging literature, but definitely can continue to grow in this area to help us implement it more across the country. This is one of the larger sub-Q DKA trials to date, so it does, again, add to that limited data that we do have available. It does also provide an example protocol for institutions to look at and adopt and adapt based on their institution needs and what they think is appropriate. Not necessarily something to follow blindly, but it gives a good starting place if you've never had a sub-Q insulin protocol before. And they really had similar patient characteristics across the various cohorts. I think including the 3 different groups showed kind of the patient population was very similar across the board. But getting into our limitations, this has limited external validities based on several things. It was a single center study, an urban setting, and a lot of us practice in various institutions. It's hard to say that it would be entirely applicable to our different settings. It was a retrospective chart review, so there's just some limitations there in terms of documentation and being able to pull that information out of the chart in retrospect. It was also underpowered, so it did have a smaller sample size and the inability to detect any true difference in those adverse effects. So that is something that the authors identified as a limitation, but still something worth mentioning. For ED length of stay and ICU admission as an endpoint, that really is multifactorial in terms of what impacts how long patients stay in our ER and how ICU beds are available. So that's going to be varied across different institutions, and a wait time in one ER is not going to be the same in a different. And that really depends on transport times and our patients. Do they have beds available? How many beds do they have available? And the size of your institution. So it's hard to say that that is going to be the same if you implemented this protocol in a different hospital. The biggest limitation of the study that I found was the fidelity endpoint itself. So they use that amount of finger sticks per hour as the marker of if this protocol was implemented appropriately and had adherence to it. But there are a lot of other potential errors for this protocol implementation to say that it's truly being followed correctly. So we don't know the doses, if patients or if providers were under or overdosing that sub-Q insulin. Was it 0.2 units per kilo? Was it 0.1 units per kilo? It's hard to say because they didn't do anything to address or analyze what doses of insulin that were actually being given. Also, the timing of sub-Q insulin administration. So it was thought that because they did the Q2-hour point of care glucose checks, that the nurses were giving insulin immediately after that point of care insulin check or point of care glucose check, but they were checking their sugars every hour. So the timing of that sub-Q insulin administration could be another thing that makes us think that this protocol wasn't followed entirely as it was written. Similarly, was dextrose added to the fluids at the correct time when their blood sugar fell below 250? Were their BMPs ordered at the correct interval and every 4 hours assessed? So there are a lot of different things that could go into this protocol being truly adhered to that were not assessed, which is a huge limitation, and also didn't assess the resolution of DKA itself. So how long did these patients go before their DKA was resolved compared between the sub-Q and the IV insulin? So those could all be further things to assess with this protocol as well. So the authors of this study concluded that sub-Q insulin is the effective treatment for mild to moderate severity DKA that had similar safety to those IV infusions, but did lead to that reduction in ED length of stay. My conclusions from this study, it's well designed. It's a good protocol, but I wouldn't adopt it blindly just off of this study alone. I'd want to see further studies assessing those things that I mentioned in terms of the fidelity endpoint, resolution of DKA, because I said it's only assessed that one area of protocol adherence, but saw no difference. Yeah, I think there's just a lot of future studies that can be developed off of this, looking, like I mentioned, those dosing, fluids, BMPs, resolution of DKA, and then assessing patient and staff satisfaction with the protocol itself. These patients are going to be getting a lot of sub-Q injections, so seeing how they feel about that versus the IV infusion, looking at the nursing staff and the amount of times they have to go in and get these finger sticks, and just the overall satisfaction with the protocol itself. Looking at safety and training requirements, how this protocol was implemented into the emergency department, and if there's room for expansion. I think most people in management would want to see if there was any cost savings associated with that as well, to see if there's potential benefits in that aspect. So that is all I have for you guys in terms of going over the trial and the background on sub-Q insulin and DKA, but I'm happy to answer any questions that you might have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only. It does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.